Okay, so my case studies named upper and lower quarter pathology management of a high school softball player. So the purpose of my case study is to discuss an impairment-based rehab following an unusual surgical repair and the evidence-based treatment of simultaneous upper and lower extremity injuries. So my patient is a 16-year-old female softball player. Upon her referral initially said that she had patellofemoral pain, but upon looking at her intake forms and her pain diagram, she actually had circled her left knee, her left lower leg, and her right shoulder. So this isn't super uncommon in the outpatient ortho clinic, but I quickly had to rethink my approach to my eval. So there is a lot going on, so if you guys need clarification from me at all, let me know. I'll stop for questions. But I will start with her left knee pain. So she initially had a left lateral compartment hernia repair in June of 2016. She didn't have a follow-up with her doctor for 4 months. And after that follow-up, she was not referred to therapy. So she had now gone back to her doctor in January and was referred to us at the beginning of February. So there was a good spot of probably 6 or 7 months where she really didn't have any care after surgery. Her biggest complaint at the time was being able to walk around school during the day. And so counsel and colleagues actually reported that lower leg hernia repairs are not common in general, but when they do occur, they're typically in the anterior compartment, and they're asymptomatic. However, when she initially started with her pain, she thought she initially had shin splints. Over time, during her last softball season, over time, the pain worsened. With each step, she felt like something was tearing in her leg, and eventually a bump grew on her leg, and it kept growing and growing until her mom made her go to the doctor, basically. So then she had the surgery, and then we were seeing her in February for some pretty bad knee pain. So for her right shoulder, she had been having shoulder pain for 2 years. She played through it with softball. She had also reported that she had had some numbness wrapping around the side of her arm. Since she hadn't played softball since her surgery, so since then the numbness had resolved for the most part, but it was just something that she didn't really understand at the time. So she just wanted to mention it to us. So her shoulder pain had been improving since she basically wasn't using her shoulder. She put it at its worst at a 5 out of 10, usually with any kind of active movement. Her biggest complaints with her shoulder were she was unable to do her hair in the morning, so she couldn't put it up in a ponytail or straighten it or whatever girls do in the morning to their hair. Her mom had to do it for her. She couldn't carry groceries in from the car because she had a lot of pain, and doing her chores, anything within a couple of minutes started pain, especially if it was over shoulder height. Her knee pain was pretty bad most of the time, 7 to 9 out of 10. Her biggest complaint again was walking, but she still had pain with things like squatting. And according to her LEFS, she was no longer running or putting, and her biggest issues again were walking and squatting. The higher score on the LEFS is better, so she was a little over 50% limited with that. And her quick dash, normally the lower score is better, so it wasn't too bad according to her shoulder pain, but her sport was actually at 100 out of 100 since she wasn't participating at all. I just wrote it down wrong. So when I initially asked her for active range of motion, she was a little apprehensive. She said that when she raised her arms over her head, that she could do it, but upon lowering them, her shoulders would get stuck, so she just tried to avoid it. And I have a video of that later on that I can show you what she was referring to. Her flexion, abduction, and extension were all greater than the normal values, as was her external rotation on her throwing arm, which was her right upper extremity and the symptomatic one. But according to Reinhold, he reported that in young overhead athletes that start to play their sport at a younger age, and that as they're growing and they repetitively throw the ball, they can actually have bony changes in the joint. So these motions may or may not have been related to what she was experiencing now. It could have been a change as she was growing. Her gross strength was a 4- out of 5, so she was pretty weak. And her right shoulder was painful, but her left one was not, but equal strength on both sides. So for her lower extremity now, range of motion was all normal, no pain at the end range or with overpressure. Strength again, grossly, she was pretty weak. She didn't have pain at her hips, but she felt like with any of the pressure I put through her leg, she felt like her hip was going to pop. That was mostly with flexion and then sideline abduction. Her left knee extension was painful, as was her left ankle eversion, which would be expected based on where her surgery was and what muscles were affected by that. I did not do a formal gait analysis, but upon watching her walk in and out of the clinic, she had decreased time in left stance, knee flexion in left stance, and then a moderate bilateral Trendelenburg. So upon palpation, there was nothing significant on her shoulder. She did say, again, that most of the numbness had returned or resolved, not returned. And for her knee, however, pretty much everything was painful. She was painful at the quadriceps tendon, patellar tendon, surrounding the edges of the patella, diffusely across the front of it. And then she had pain extending from the head of her fibula down through the soft tissue by her spar, and then spreading inferiorly. So I don't know, her spar was basically right here, just so you guys know. And then she also had decreased scar mobility, and it was painful. She was really sensitive over the scar itself. Functionally, she could reach about a quarter squat before the onset of her pain, and we deferred the single leg squat due to the pain with the double leg squat. So due to the findings with her range of motion, I chose to do the anterior and posterior apprehension tests, which have been found to be good tests to identify general laxity for the static structures of the shoulder. Both were positive. The sulcus sign was also positive, as was the Jones repositioning test. So as we held her scapula in place and we had her go through flexion and scaption, she reported an improvement in her symptoms. Both ligament tests were negative in the knee, and she did have hyperextension at her bilateral elbows, but the rest of the Baden score was negative. So for her physical therapy diagnosis, right shoulder instability, and for, I guess, more her left lower extremity than her knee itself, she had decreased left hip, knee, and ankle strength, which may have been contributing to the pain and the gait abnormalities she was having. So the symptoms that she was presenting with seemed similar to quadricep and patellar tendinopathy, and as well as her referral was for patellofemoral pain. So we didn't necessarily diagnose her with this, but I did use research on these topics to help guide the interventions that I chose later on in the care. And for her prognosis, there was so much going on, I didn't really know what to choose, but I did choose fair because she was active and motivated, definitely active prior to the surgery. And there was research that stated knee pain, excuse me, under 52 weeks was a positive prognostic factor. But I'll discuss the insurance difficulties in the next slide, but the chronicity of her right shoulder pain, and she also had a failed bout of PT for her shoulder, and the poor level of her post-surgical care, I wasn't sure exactly how much that would affect her. And I couldn't find research on it, but for the numbness on the outside, the lateral side of her shoulder, when referring back to an anatomy book, there is a branch of the axillary nerve that wraps around from the back into the side. It's the lateral cutaneous branch. So due to the weakness and the potentially instability she was having, she wouldn't really be able to control the eccentric portion of her throw. So it would make sense that that nerve could potentially be put on stretch, which would cause the numbness. Since she stopped throwing the softball, that stretch may have been alleviated, essentially getting better over time. So for her plan of care, she was on Medicaid, so it took 3 weeks for her approval to go through. We could not schedule her until that approval came back to us. So they gave us a certain number of visits to complete by a certain date. So normally we would have had 7 weeks to spread out these visits, but we had 4 by the time we got the approval. So we did 2 to 3 times a week for 4 weeks, wherever we could get her in. And then I will discuss the interventions and outcomes towards the end. So her health condition again, right shoulder instability and then patellofemoral pain. She did have decreased strength deficits in both her right upper extremity and left lower extremity. And she did have decreased strength and signs of instability in her right shoulder, but I wasn't sure if the weakness was leading to the instability or vice versa. So I did treat both. Her activities ranged from basic functional ones, from walking, sitting and standing and brushing her hair, to return to sport activities like running and throwing. Her main environments were her high school, home, and the softball field. And she was a teenage female athlete with some moderate apprehension towards her right shoulder, at least. So to give you an idea of how much walking she had to do during the day, this is a Google Maps view of her entire school campus. So normally she'd park her car in the lot, and her first class was all the way across, like over here on the other side. She said she'd have to cross campus at least 2 or 3 times a day between classes. She had about 5 minutes to do so. And I didn't mention this earlier, but she wasn't able to participate in softball this spring, but she was still a manager, so she still wanted to participate. So she would stay after school, and she'd have to be on the softball field and then walk back to her car at the end of the day. So it was, to me, a lot more walking than I did when I was in high school. So here is a, hopefully, video. That's not her name, by the way, I'm just saying that. You can see as she lowers it down, she kind of gets what she referred to as getting stuck. Neither shoulder looks good, but her right is definitely worse than her left. And that's what she said she'd have to do to get her shoulders. She'd just roll her shoulders back, put them back in. Okay. Any questions so far? We all on the same page? Okay, so since there was so much going on in her exam, I didn't do any treatment, but I did send her home with a home exercise plan for desensitizing and some scar mobility to start out with, some shoulder isometrics, but we deferred flexion because she had pain with it, and then straight leg raises to work on her hip strengthening. But again, since it took 3 weeks for her to get back in for her first follow-up, she said she had stopped doing her straight leg raises after a couple days because every time she would raise her leg, she felt like her hip was going to pop. So she stopped doing them, and at times it was painful. Her shoulder did feel better, and she said she did do some of the scar mobility stuff, but it wasn't every day. So I used this to adjust her home exercise plan. I gave her a new one, and then used it to kind of guide the interventions that we chose in the clinic. So the interventions that were focused strictly on her left lower extremity, Willie et al. Reported that for patients that represent similar to patellofemoral pain, it's important to focus on posterior lateral hip strengthening. So there's a handful of the exercises that we use to focus on that. Whittingham also discussed a study that assisted with taping for knee pain. So he called it McConnell taping. It's the one in the top left. He reported that it doesn't matter which way you glide the patella as long as it made them feel better. So when I immediately glided her patella, she reported an immediate improvement in her symptoms. So at the beginning of each session, we would add the tape so she was able to tolerate more weight-bearing things throughout the hour. And we also use something called blood flow restriction training, which is relatively new to physical therapy, I think, the last couple of years. So Hughes did a systematic review on it for the science behind it as well as the safety and effectiveness. But essentially, so it's the bottom picture over here, the strap around her leg. You want to restrict the blood flow from the most proximal joint, so as close to the hip as you can get it. And it creates a hypoxic environment in the muscles distally. So normally it brings them to fatigue faster. So normally you want to train them at 70% of their 1 rep max to gain strength. But when you do the blood flow restriction training, you can actually get similar results at 30% of their 1 rep max. So for people that are in a lot of pain and can't tolerate 70% of that, we can still get similar strength benefits at a much lower load. So normally with BFR, there's actually a machine and a cuff, and it's really accurate. Those that cost around $5,000, so they're not super practical for every clinic. But Wilson did a study, what he called practical BFR, when he used straps like the ones we have here. And they said that if you can get the patient, and it's a subjective measure, so they have to rate it at a 7 out of 10. So you have to pull it pretty tight. It has to be kind of uncomfortable to get the similar benefits. But you can still get those strength gains. They're not quite as quick and they're not quite as good as with the machine, but they're still better than excellent exercise by itself. And we also did some isolated work for her eversion and dorsiflexion. So for her shoulder, Cools reported that for patients with glenohumeral instability, it's important to focus on neuromuscular re-education to stimulate the rotator cuff activity. She recommended that it be done in elevation, but since my patient did not really tolerate elevation at all, we propped her up on pads so that we could still train her in that range. Initially, she also reported that eccentric exercise is better. So you can maximally load the muscles and get more strength gains faster. So initially she started without any weight, and we would just have her lower her arm down and then lift it back up. And by the time we did her progress note for that, at the end of that 4 weeks, she was able to use 2 or 3 pounds. We did it in abduction and flexion. We also did some rhythmic stabilization and some specific rotator cuff work, as well as Coles also reported that prone exercises can also activate the scapular muscles as well as the rotator cuff. And we deferred active range of motion just in general because she just didn't like it and we weren't getting a lot of benefit out of it. So I also tried to use exercises that would combine both the upper and lower extremity, kind of like bang for your buck kind of stuff. Coles reported that if you integrating the kinetic chain, so basically from the floor through the lower extremities, trunk, and upper extremity, you can activate the scapular muscles more. So like using the posterior oblique sling, if you have them row on their right shoulder and stand on the left. Normally she said single leg squat, but my patient couldn't tolerate initially, so we just had her do a single leg stance. You can further along, she was able to do a squat. So this was towards the end of her care, which that worked out perfectly for me because her right shoulder and left lower extremity were the issues. So I love that. Side planks have actually been shown to activate the gluteus medius the most out of any other exercise. And since she had to stabilize her shoulder at the same time, it worked on both of them. I like to use the deadlift with her because if I cued her to pull her shoulder blades together, she was activating and maintaining that control at her shoulders and also getting that posterior chain strengthening at the same time. And then we did toe kneeling for hip strengthening and incorporated some functional movements as well. So the majority of her progressions were dosed to her tolerance. Research said that if you kept the pain at a 2 to 3 out of 10 through each exercise, and it would resolve within a couple of minutes, that was an okay level to keep them at. You could keep them there, essentially progress them. But if it got any higher than that, or it took more than a couple of minutes to resolve, we would just lower her load, whether it be reps or weight at the time. And as well for the length and intensity of her soreness, it's okay to last for 24 hours after she completed the exercise, but it needed to be continually decreasing. So if she came in saying like she was sore for 2 days versus just 1, we would scale it back that day, either keep the weight the same or scale it back a little bit more if she was really sore. So her progress note happened to be on my last week, so that was perfect. And the majority of her measures did improve, I just wanted to point out for her knee pain, she did put it at a 7 out of 10, which was the same as the initial eval. But throughout the weeks, the time that I worked with her, it really varied. It was like all over the board. Average was probably a 4 to 5 out of 10. The week before, she did tell me 3 out of 10, but I think she either had a bad day or it was just something that was out of the norm. So that was why there really was an improvement there. Her quick dash and LEFS didn't have necessarily clinically significant improvements, but I didn't really feel like it captured how much better she was doing because her gait abnormalities were almost gone. She had a mild Trendelenburg, but she reached full knee extension and stance, and her stance times were equal. And she said she felt stronger with her shoulder and her knee throughout her daily activities. Functionally, she was pain-free to parallel, and she could do a single leg squat by the end, or at least the 4 weeks that I worked with her. And she was able to put her hair up in a ponytail, which was big news for her. And then she was able to tolerate carrying groceries in, but she was still had a difficulty lifting them up to the counter. So she'd use her left arm to help her raise it up. So in summary, we discussed how to approach an unusual surgical repair based on impairments, evidence-based approach to treating simultaneous injuries, and how to incorporate the kinetic chain to treat multiple impairments at one time. So if I did have second chances, I would probably have her fill out an FABQ because as I got to know her and we talked more and she'd open up more about stuff at school, she kept mentioning how much stress and anxiety she was having, even though she was always very laid back. So it wasn't something I caught in the beginning. And she was also she wasn't afraid of moving her shoulder, but it seemed like she just didn't want to use it, so she avoided it. So I just would have liked to dig into that a little bit more. I didn't do manual therapy during my sessions because I gave it to her at home, but I don't necessarily think she was as compliant as I would have liked her to be. And I could have, I think, made more of an impact on that part of it if I had done it in the clinic. The limitations were definitely the time management. I felt like I could never get through everything I wanted to get through in an hour. And as well as the insurance, so her progress note was the last week I was there, about 3 weeks ago, and she just got back into the clinic today. So there's still another 3-week gap. So frustrating, she did have things to do at home, but obviously not as good as care she would have gotten with us. And my questions, which I don't know if you guys can help me with, I had no idea how to help her minimize walking at school. I could not figure that one out. And I was just curious, based on the way her knee pain was presenting, it was like all over the place all the time, if maybe some of that pain was due to central sensitization instead of just like the strength deficits and stuff that she was having. So, any questions? Yeah. Yes.
So rather than decreasing the amount she has to walk at school, because I agree with you, that's going to be really hard to do getting to class and everything. Did you think about doing any graded exposure type stuff on the Pathology you guys have in your play? So maybe walking at a lower load for your tolerance to that.
I did not. Good point.
This is just a curiosity.
Yeah.
But what type of exercises were you doing with blood restriction? Mm-hmm. And at what time during treatment session were you doing?
So we always did the BFR at the end because it fatigues you a lot really quickly. We did long arc quads initially, and then I'd add some weights to her ankle. And then when she was able to tolerate the knee extension machine, I would put her on the knee extension machine. And I think we had a shuttle as well that would put her on her back. She'd be at 90-90. She'd do a shuttle. So all focused towards knee extension, basically.
Okay. Did she ever have that popping sensation in her right leg, or was it only in her left hip?
Both.
It was both. And then was that something she ever experienced functionally, or you only
all the time? So she felt like she had it every time she would walk, just randomly. She'd just feel like her hip would pop. We gave her, for her new at-home exercise plan, we gave her clams, sideline clams, but as well as like banded marching and abduction to help just strengthen around the entire hip.
And if you used the McConnell taping that she reported that it helped, did you let her leave it on after the session, or?
I let her leave it on for the rest of the day and told her to take it off.
Who was the CIU with?
Devin Jordy.
Who
Fred Baldwin was my other one, but I didn't spend
What's
as much time with him. Fred was my other one, but I didn't spend as much time with him.
I'm still a little confused regarding the surgery.
Mhm.
Right? Because we talked surgery, and then somewhere we went to the IAP, it turned into the telefemoral.
So
I didn't really see any data that supported the telefemoral, so can you speak to that?
yeah, so she had the surgery in June, which was solely, she wasn't having knee pain before the surgery,
Did she have any symptoms before the surgery?
other than the pain in her lateral leg, no.
Okay.
So she said, I don't know.
Okay.
So after she had the surgery and didn't go to therapy, that's when her knee pain started, and then it spread down her leg.
So what was the original pain?
Like after her surgery or when she came in for us?
So before she even saw the doctor. Something pops on her leg, mom says go, what's she feeling then?
She just said she felt like a shearing pain on the side of her leg. That's what she told us.
Okay.
They told her.
So so was that the telefemoral?
No.
Okay. What was the condition, or what test might you do now regarding that?
The hernia itself.
The repair?
I don't know.
Okay. So just based on the location,
Mhm.
I mean, I'm thinking like neurodynamics. I'm really interested in what's going on with neurodynamics.
Okay.
I think you can see why, right?
Mhm.
Pretty close to perineal, and so pain can go distally, it can go proximally too, right? So really, I'm smelling more of that than I'm smelling.
Okay.
I think we need data.
Oh, so it was more, and I didn't mention it, but it was the symptoms that she was having during the day, like just the walking and the low load on the knee itself.
That could be neurodynamics, that could be related to soft tissue, that could be related to any number of factors, right? So, I mean, I'm more, like, if I use my hands on her, I go after that surgical site, see what the heck's going on there now, and then try to do more neurodynamics and look at that, right? What did you see at the, so what do you think her diagnosis was? Shoulder, or health condition?
If I had to pick one, like general instability.
With the shoulder, did you assess T-SMART at all with seeing that there is altered like scapular?
No. I didn't really feel like the mobility was necessarily her issue. If anything, she would be hypermobile versus hypo. No, done. Okay.